welcome to this IAC webinar, which is brought to you by the International Academy of Cytology. Today we have a very popular topic and a very popular presenter in Dr. Michiya Nishino, who's the Director of Head and Neck Pathology and Program Director of the Cytopathology Fellowship at Beth Deaconess Medical Center, as well as an Associate Professor of Pathology at Harvard Medical School. He is an Associate Editor for Cancer Cytopathology and serves on several other notable journals in cytology and histopathology. He was the lead author of the second and third editions of the Bethesda System, including spearheading the new molecular testing chapter for third edition, which is certainly one of Michiya's great areas of expertise. And his primary clinical and academic interests include surgical pathology and cytopathology of head and neck, thyroid, salivary glands, and the application of molecular testing in these settings. He is, of course, well recognized for all his educational activities, and he really loves to teach and engages with the cytopathology community through his lectures, workshops, and through service in various professional societies. And on a personal note, I am absolutely delighted to listen to Michiya once again. He's a very pleasant friend and a lovely colleague, and I can't wait for any opportunity to listen to him. So here we are. Dr. Nishino, the floor is yours.
Oh, thank you very much, Dr. Chandra. And hello, everyone. It's a delight for me to be with all of you today, and I'm grateful to the International Academy of Cytology for this invitation. Let me go ahead and share my screen here. All right, I think we're all set. I think get that all ready. All right, so for this session, we're going to build a simple and practical framework for understanding how cytopathologists and molecular pathologists take the cells that are on a thyroid FNA slide and translate them into actionable information that can be used to help guide the management of our patients' thyroid nodules. So our goals over the next 45 minutes or so are to reinforce a simple pattern-based approach to thyroid cytology so that we can understand why some thyroid aspirates are simply indeterminate for cancer and could potentially benefit from ancillary molecular testing. We'll cover the main genomic alterations that are often tested for in thyroid FNA samples, and then we'll briefly discuss the different approaches that are currently available for molecular testing in thyroid FNA samples. Because by understanding why we use molecular testing, what we're testing for, and how these tests are performed, each of us can help promote the judicious use and interpretation of these molecular tests in our respective practice settings. All right, so let's begin. We'll start with the pattern-based approach for classifying thyroid nodules. Oh, okay, I'm just checking the chat real quick and making sure there's nothing. Okay, everything is going okay. All right, so we'll start with this pattern-based approach. So for some context, it's helpful to think about thyroid FNAs as primarily a risk stratification tool. And for those nodules that meet clinical and sonographic criteria for biopsy, FNA helps us stratify those nodules that are low risk and thus safe to monitor clinically versus those that are intermediate to higher risk and require surgery, either for diagnostic or therapeutic purposes. Globally, there are a number of standardized reporting systems for thyroid cytopathology, and although there are some variations in the number of categories and the preferred terminologies, there are really more similarities than differences here. Now, all of these reporting systems have categories for non-diagnostic, overtly benign, and overtly malignant categories, as well as the so-called indeterminate categories that are highlighted here in blue. And for the purposes of today's discussion, I'll use the terminology of the Bethesda system, but the concepts that we'll be discussing can be broadly applied across each of these reporting systems. For the purposes of today's discussion, here's the Bethesda system. We're currently in its third edition with the recent publication last summer. And the 6 interpretive categories of the Bethesda system are listed here in the first column. And Each of these categories is associated with an approximate risk of malignancy, shown here in the middle. And based on these approximate risks, the Bethesda system recommends a particular course of management. So our first big question is, how do we take cells on a cytology slide like this one and bend them into one of these 6 interpretive categories? Well, for most thyroid FNAs, we rely on just 2 main tools to help us classify these thyroid nodules. Tool number 1 is evaluation of a cell's nuclear detail, and tool number 2 is evaluation of cellular architecture, or how these cells are grouped together on a slide. And we'll take a look at each of these 2 tools briefly, starting with nuclear atypia first. Nuclear atypia is really referring to the nuclear features that are characteristic of papillary thyroid carcinoma. And these changes can occur along a spectrum. In these boxes, we have histologic images of thyroid lesions with varying degrees of nuclear atypia. So starting here at the bottom, on the low end of the spectrum, we have a totally benign hyperplastic or adenomatous nodule with small, round, and dark nuclei. And as we move upwards, we have increasing degrees of atypia, including some nuclear enlargement and chromatin pallor, some subtle longitudinal grooves, and up here at the top, the overt nuclear atypia of classic papillary carcinoma, with not only the nuclear enlargement and chromatin pallor, but also numerous grooves and irregular contours and even intranuclear pseudo-inclusions. These nuclear changes that we see on histology translate quite well to FNA cytology specimens, as shown here in these circles, making the assessment of nuclear atypia one of those key features that cytopathologists will look for in every thyroid FNA. All right, so that was nuclear atypia. The second main tool that we examine in thyroid FNAs is architecture. Histologically, normal thyroid follicles and macrofollicular lesions have these abundant colloid-filled sacs that are lined by a sheet of follicular cells that are pretty evenly spaced from one another. And as these follicular cells proliferate, as they do in neoplasia, they can do so in a couple of ways. They can form these crowded microfollicular groups with overlapping nuclei and scant colloid, as shown here in the middle. Or alternatively, these dividing cells can make room for themselves by forming branching papillary structures with fibrovascular cores. These architectural features each have cytologic correlates that can be seen on FNA samples, as shown in the boxes below. So, using just these 2 tools, nuclear features, as we saw in the prior slide, and architectural features, as shown here, using just these 2 tools, we can start building an idealized conceptual framework for classifying the vast majority of thyroid FNAs. So in this simplified conceptual model, we have nuclear atypia on the y-axis, and qualitatively, we stratify them into mild, moderate, or severe. And on the x-axis, we have an aspirate's architectural features, which can vary from flat, 2-dimensional macrofollicular sheets to crowded microfollicular groups, all the way to some papillary structures. All right, so let's see how we can apply this conceptual model to a real-life case. Here's a gross image of a totally benign hyperplastic or adenomatoid nodule in a patient with multinodular goiter. It's a pretty well-circumscribed nodule, heterogeneous with some cystic areas and a pretty gelatinous cut surface. Histologically, this nodule consists of large dilated follicles. So this is a classic example of a benign macrofollicular nodule. And on higher magnification of the histologic section, there's abundant colloid, and these follicles are lined by evenly spaced cells with small, round, dark nuclei. So you can imagine that if we stick a needle into this nodule and aspirate its contents, then we would expect to see a variably cellular aspirate with abundant colloid, as shown here and here. And these follicular cells are arranged in flat sheets with evenly spaced nuclei. And these nuclei are small, they're round and dark, evenly spaced from one another, resembling a honeycomb-like structure. And just keep in mind that in real life, macro follicles are spherical. Right? They're like beach balls that are covered by evenly spaced polka dots representing nuclei. And of course, on histologic cross-sections, these spheres look like circles that are lined at the periphery by nuclei and filled with colloid. And you have to imagine, what would happen if we took these beach balls and took a scissor and shredded them all up? we'd see flat, torn, sheet-like fragments with evenly spaced polka dots, right? And by the same token, when we fine needle aspirate a macrofollicular lesion, what we get on the FNA cytology slide are flat, two-dimensional sheets with evenly spaced nuclei. And because most totally benign hyperplastic or adenomatous nodules present cytologically with macrofollicular architecture and minimal nuclear atypia, anytime cytopathologists encounter an aspirate that occupies the intersection of these conditions, we can confidently make a diagnosis of benign. And our treating clinicians understand that aspirates that we place in this category have a very low risk of cancer, perhaps 3 to 4%, which represents the false negative rate of thyroid FNAs in general. All right, so now moving on to the malignant end of the spectrum. When we FNA a papillary carcinoma, the aspirate shows numerous cells arranged in crowded sheets or papillary fragments with branching arms like these. And on higher magnification, there's nuclear enlargement and overlap. There's nuclear contour irregularity with longitudinal grooves and internuclear pseudo-inclusions, and chromatin pallor as well. When all three of these nuclear features are present, nuclear enlargement, nuclear irregularity, and chromatin pallor, when all three of these features are present, we would consider the nuclear atypia to be quite prominent and diagnose the aspirate as being malignant, as they represent either classic papillary carcinoma or one of its equally malignant papillary carcinoma subtypes. And our treating clinicians understand that aspirates that we place in this category, malignant, have a near 100% probability of malignancy. Now, along the same lines, aspirates that we classify as suspicious for malignancy demonstrate cytologic features that are worrisome for cancer. And we're usually talking about papillary carcinoma here. But the sample falls short of a malignant interpretation because of quantitative or qualitative reasons. And some examples include aspirates where there's marked nuclear atypia. I mean, just look at that internuclear pseudo-inclusion right there. But this marked atypia is present only in a subset or a small number of cells in an otherwise pretty benign appearing background. The focality of the atypia would hold me back from calling this outright malignant, so I would classify such cases as suspicious for malignancy instead. And here's a different case where the nuclear atypia is pretty moderate in degree in terms of having some pallor and nuclear enlargement, and that atypia is present diffusely throughout the sample. So in a case like this, the degree of atypia qualitatively falls short of what I would require for definitive classification as papillary carcinoma. We don't see a lot of nuclear grooves or readily identifiable internuclear pseudo-inclusions, for instance. So classification as suspicious for malignancy could be appropriate here. So coming back to this idealized matrix, you can think of those few aspirates that we classify as suspicious for malignancy as occupying that region where the degree of nuclear atypia falls short of overt papillary carcinomas. And also keep in mind that obscuring factors like blood or preparation artifact can limit our ability to be definitive about calling an aspirate malignant. And that might be another reason why we use the suspicious for malignancy category instead. Altogether, aspirates that we place in this category have an up to 75% probability of malignancy compared to the near 100% probability of malignancy for those aspirates we place in the malignant category. So far, so good, right? So our next big question is, how do cancer risks like this, or interpretation of benign, suspicious for malignancy, or malignant, how do these inform management decisions? Well, in general, the clinical management of thyroid tumors is driven by two related but distinct notions of risk. Number one, the risk that a nodule is malignant. And number two, if that nodule is malignant, what is the risk of adverse outcomes? And here we're talking about the risk of metastatic disease or regional recurrences. And we can collectively envision both of these different types of risk on a disease risk spectrum. In this simplified management algorithm following a thyroid FNA, Those that we classify as cytologically benign are generally safe to monitor clinically because of their very low probability for cancer, while those that we classify as suspicious or positive for malignancy are generally referred to surgery. So that all seems really straightforward, right? Why would we even need ancillary testing? Well, as you may have guessed, it's because not all thyroid FNAs are black or white, and in fact, anywhere from 15 to 30% of thyroid FNAs fall into a gray zone, where the malignant potential of a nodule remains unclear based on the cytomorphology alone. And it's often those aspirates with crowded microfollicular architecture and mild to moderate degrees of nuclear atypia that have a broad differential diagnosis that includes benign and premalignant lesions, such as follicular adenomas and NIFT-P, as well as their invasive malignant counterparts, follicular carcinoma and invasive encapsulated follicular variant and papillary carcinoma. The cytologic features of these tumors overlap significantly, and definitive distinction really requires assessment of invasive growth, which we simply cannot make on FNA cytology specimens. We really require histopathology for that. The two main indeterminate categories in the Bethesda system are atypia of undetermined significance and follicular neoplasm. And we'll briefly go over each of these categories, starting with the follicular neoplasm category. To understand this category, let's take a look at this example of a follicular carcinoma, which is grossly encapsulated, but demonstrates microscopic evidence of tumor invasion through the fibrous capsule of the tumor and into some capsular blood vessels as well. While this histology is diagnostic of malignancy, its cytology is not. And that's because apart from the presence of capsular and vascular invasion at the periphery of a nodule, follicular carcinomas can look virtually identical to follicular adenomas. Now, both of these tumors are cellular, consisting of cytologically bland follicular cells arranged in these crowded microfollicular and trabecular structures with sparse colloid. So fine needle aspiration of either of these nodules would yield essentially the same thing. Cellular aspirates with groups of crowded follicular cells, overlapping nuclei, and these are basically the cytologic correlate of microfollicular and trabecular structures, without significant nuclear atypia and without much colloid. These cytologic findings, they're strongly associated with a neoplastic process and are thus diagnosed as follicular neoplasm, but we cannot tell if it's a benign neoplasm or a malignant one based on these cytologic features. And that's what makes it indeterminate. Overall, aspirates that we place in the follicular neoplasm category have a cancer risk or probability of about 30%. And coming back to this simplified matrix, aspirates that we place in the follicular neoplasm category occupy that gray zone at the intersection of mild to moderate degrees of nuclear atypia and crowded microfollicular architecture, where the main differential diagnosis is follicular adenoma versus follicular carcinoma, and perhaps some cases of NIFT-P and its invasive counterpart as well. Just as a side note, the first two editions of the Bethesda system suggested the term suspicious for follicular neoplasm as an equivalent alternative name for this category. But for the current third edition, the Bethesda system has removed the suspicious for terminology and now endorses the simpler and clearer term follicular neoplasm instead. All right, so in contrast to that follicular neoplasm category, atypia of undetermined significance is a more heterogeneous category with an element of subjectivity as well. And it's helpful for us to think about AUS in terms of two main subcategories. So first, we have those AUS cases with nuclear atypia. And these are those aspirates where cells show some features worrisome for papillary carcinoma, but fall short of a suspicious for malignancy interpretation. And like we discussed a few slides ago, why an aspirate would fall short of a higher risk or more definitive category can be due to quantitative reasons, such as that aspirate where cells show pretty marked nuclear atypia, but only in a small number of cells, or the reason for falling short can be qualitative, as in the examples here, where the extent of nuclear enlargement or chromatin pallor or nuclear irregularity is mild to moderate in extent, not quite reaching the degree of nuclear atypia we would typically want to see for a suspicious for malignancy interpretation. And coming back to this idealized matrix, think about those AUS cases with nuclear atypia as those with borderline nuclear changes that fall short of a suspicious for malignancy classification. All right? Now, the remaining types of mild atypia that fall into the AUS category are currently collectively subclassified as AUS other, according to the third edition of the Bethesda System. And an example of that would be an AUS case with architectural atypia, where there are increased microfollicles, as shown here, but the aspirate falls short of a follicular neoplasm interpretation because of the low overall cellularity of the sample, as shown here, or because these microfollicular groups are admixed with a substantial, albeit still lesser, fraction of macrofollicles. So cases classified as AUS other because of architectural atypia represent those cases with borderline microfollicular architecture that precludes a benign interpretation on the one hand, but at the same time falls short of a follicular neoplasm interpretation. And as a side note, the first two editions of the Bethesda System suggested the term follicular lesion of undetermined significance, or FLUS, as an equivalent alternative name for this category. But in this third edition, the Bethesda System removed FLUS as an option, really just going all in with the AUS terminology instead for simplicity. The main challenge with the AUS and follicular neoplasm categories has to do with what the best management options would be for patients with these nodules. And at cancer risks of about 22% for the AUS category, and at cancer risks of about 30% for the follicular neoplasm category, these cancer risks are generally considered too high to send all patients towards a watchful waiting approach, at least here in the United States. And there are global differences, as we'll touch on at the end of this session. But on the other hand, we know that at these moderate levels of cancer risk, if we send all of these patients for surgical referral, the vast majority of these nodules would be classified as histologically benign at these probabilities. And we would wonder if surgery could have been avoided for patients with benign nodules if there were just a better way to risk stratify these nodules preoperatively. And that's where molecular testing comes in. Currently, the primary role of molecular testing in thyroid cytology is to help refine the cancer risk of aspirates in these lower risk indeterminate categories so that we can separate those nodules that are molecularly low risk and follow them by a watchful waiting approach while selecting those others that need surgery, with the extent of surgery, lobectomy versus total thyroidectomy, depending on a number of factors, including molecular testing results in some cases. So with this framework in mind, let's briefly review the key molecular alterations in thyroid tumors. And we're going to focus on genomic alterations for this webinar, mutations, insertions, and deletions in DNA, and gene fusions as well. Here in this cartoon, these colors and shapes serve as visual cues for malignant, low risk, and benign thyroid neoplasms, respectively. For instance, the BRAF V600E mutations and these other gene fusions that are listed here, these are closely aligned with classic papillary carcinoma, as well as the tall cell subtype, infiltrative follicular variant of papillary carcinomas, and some others as well. In contrast, RAS mutations and these other RAS-like alterations here can be found in both benign and low-risk neoplasms, like follicular adenoma and NIFT-P, as well as their invasive malignant counterparts, follicular carcinoma and invasive encapsulated follicular variant of papillary carcinoma. Along the same lines, mutations in mitochondrial DNA and chromosomal copy number alterations can be seen in both benign and malignant oncocytic neoplasms. Now, importantly, mutations in P53 and a TERT promoter region, especially when these alterations co-occur with one of the driver alterations listed up here, these can be seen with increased frequency in biologically aggressive cancers like differentiated high-grade, poorly differentiated in anaplastic carcinomas. And some additional genotype-phenotype correlations to be aware of in thyroid neoplasia includes GLIS gene arrangements in hyalinizing trabecular tumors and RET mutations and RAS mutations in medullary carcinomas. A key point here is that tumors harboring the BRAF V600E mutation, or these other gene fusions that are listed here, these are collectively known as having BRAF V600E-like molecular profiles because these tumors share similar gene expression profiles as well as similar clinical and pathologic features. And in the context of thyroid FNAs, detection of any of these BRAF-like alterations in an FNA sample is virtually diagnostic of malignancy. All we see is red here in the differential diagnosis. There are really no benign neoplasms that are known to harbor these alterations in the thyroid. In addition to the BRAF V600E mutation itself, gene fusions involving the RET proto-oncogene, ALK, the BRAF gene, NTRK, and MET, these are all considered BRAF-like in terms of their effect on thyroid neoplasia. These tumors tend to grow in an infiltrative fashion, usually without a well-defined fibrous capsule. Classic papillary carcinoma, that's the archetype of a BRAF-like tumor with these arborizing, finger-like papillary projections, overt nuclear atypia with nuclear enlargement, chromatin pallor, nuclear irregularity, and pseudomonas calcifications are pretty typical of BRAF-like classic papillary carcinomas as well. Tall cell papillary carcinoma is also famous for being BRAF-like, and these can be recognized as at low magnification by having these eosinophilic, elongated, tram track-like architecture, and on high magnification. Of course, it has a tall cytomorphology with cell heights that are 3 times as tall as they are wide. And tall cell papillary carcinoma also well known for having overt nuclear atypia with nuclear enlargement, nuclear irregularity, with lots of longitudinal grooves, and often readily identifiable internuclear pseudo-inclusions as well. So that's BRAF-like tumors. In contrast, RAS mutations and these other RAS-like alterations, these are specific for follicular pattern neoplasia oftentimes, but not necessarily for malignancy, because these RAS-like alterations can be seen in benign and low-risk neoplasms as well as their invasive malignant counterparts. And just to reinforce this point, the differential diagnosis of a tumor when we identify a RAS-like alteration includes non-invasive benign and indolent tumors like follicular adenomas and NIFT-P, as well as tumors of uncertain malignant potential with equivocal invasiveness, all the way to carcinomas with varying degrees of encapsulation and invasive growth. So the detection of a RAS-like alteration in a thyroid FNA, just think of that as being molecularly indeterminate for cancer. And a diagnostic lobectomy is often pursued for definitive classification and diagnosis of that tumor. That's very different from a BRAF-like alteration, isn't it? If we identify a BRAF-like alteration in a thyroid FNA, that's virtually diagnostic of cancer. But a RAS-like alteration, it's not definitively malignant. So in addition to the HRAS, NRAS, and KRAS mutations, keep in mind that there is a type of BRAF mutation involving codon 601 called the K601E mutation that is also considered RAS-like in terms of their effect on thyroid neoplasia. Mutations in DICER1, EIF1AX, PTEN, and gene fusions involving PPAR gamma or the thyroid adenoma-associated gene DADA, these are all considered RAS-like alterations. Most of these RAS-like alterations are grossly well-demarcated tumors, and here's an example with a dual HRAS and EIF1AX alteration. It was encapsulated, non-invasive, shows a follicular growth pattern throughout, and had pretty bland nuclear features, diagnostic of follicular adenoma. So that's a very typical RAS-like tumor. Here's yet another RAS-like tumor, this one with a PAX8 PPAR gamma fusion. Also grossly well demarcated, but microscopically showed this hook-like or mushroom-like invasion of tumor through the tumor capsule, diagnostic of follicular carcinoma. And here's yet another RAS-like tumor, also grossly well demarcated, thinly encapsulated. There was no evidence of capsular or vascular invasion. had a follicular growth pattern throughout, and this one had some nuclear atypia in terms of some longitudinal grooves, nuclear enlargement, chromatin pallor, uh, checking off all the diagnostic criteria for NIFT-P. In this particular case, Harvard and NRAS mutation. The BRAF-like versus the RAS-like dichotomy is an important concept for everyone to take home with you for your clinical practice. The detection of a BRAF V600E mutation or one of these BRAF-like alterations is essentially seen only in malignant tumors. And it's diagnostic of malignancy if you find it in a thyroid FNA sample. On the other hand, the detection of a RAS-like alteration is seen in both benign and malignant follicular pattern neoplasms. So the detection of a RAS-like alteration, think of that as being molecularly indeterminate for cancer, and that's usually followed by a diagnostic surgery for definitive classification of tumor into one of these categories. And finally, just keep in mind that the detection of multiple genetic alterations in a thyroid FNA sample, especially p53 mutations or TERT promoter mutations, co-mutated with one of the driver alterations listed at the top, that should raise concern for a potentially aggressive cancer with a higher risk of adverse outcomes. All right, so that brings us to the final part of this webinar, where we'll briefly discuss the different molecular testing platforms that are used for thyroid FNA samples, starting with single gene testing for the BRAF V600E mutation. Single gene testing for BRAF V600E has a high specificity and high positive predictive value for papillary carcinoma, but it's limited by a low negative predictive value because the absence of this mutation does not rule out malignancy. Now, over the years, the breadth of molecular testing panels has increased from a 7-gene panel that covers the most commonly mutated and fused genes in thyroid cancer to an even broader next-generation sequencing-based oncogene panels, and finally to more complex combined genotyping and gene or microRNA expression profiling panels that are offered mainly by commercial reference laboratories here in the United States. And with each of these developments, there have been incremental improvements in the negative predictive value to the point that a negative molecular testing result using one of these combined complex genotyping and expression profiling panels can essentially help rule out malignancy with cancer risk that's close to 3 to 4% if this molecular test is negative. And together with this increasing breadth in the panel, there has been an increase in the breadth of positive predictive values that's also offered by these tests. It's important to keep in mind that bigger test panels are not necessarily better because the most appropriate and the most cost-effective test will really depend on your practice setting. Generally speaking, here in the United States, there's a relatively low tolerance for uncertainty. And historically, both patients and treating clinicians have tended to favor diagnostic surgery to help deal with cytologically or clinically indeterminate nodules. So in this sort of paradigm, if we're trying to move towards a more conservative management approach, a molecular testing with a high negative predictive value, such as these large, complex, combined, commercially offered testing panels, a test with a high negative predictive value like this one would be the most beneficial for our patients because these panels help us exclude malignancy and can direct these patients towards non-surgical management. Now, on the other hand, Dr. Ken Ichikakudo and others have shown us that in Japan and in other Asian countries, patients and clinicians generally recommend and prefer a conservative, watchful waiting approach for these clinically or cytologically indeterminate cases, really reserving surgery for those cases that are either suspicious or positive for cancer. So in this type of scenario, a smaller molecular testing panel and perhaps even single gene testing for the BRAF V600E test might be sufficient to help identify which of these indeterminate nodules are most likely to benefit from more urgent therapeutic surgery. So altogether, it's important for all of us to recognize that globally there are different management guidelines, different attitudes about risk tolerance, and even different thresholds for reporting atypia in these cytology samples, and all of which influence whether molecular testing is used at all in a particular setting, and if it is used, which molecular test would be the most appropriate and cost effective. Now, to close our discussion, we're going to explore three emerging roles for molecular testing in thyroid FNA samples beyond their established diagnostic role for risk stratifying cytologically indeterminate thyroid nodules. We've talked a little bit about the well-characterized associations between a tumor's molecular profile and its phenotype, which includes tumor prognosis. And by tumor prognosis, we're really referring to the risk of structural disease recurrence, distant metastasis, and cancer-related death, which molecular tests can inform to some degree. In general, tumors with an isolated RAS or RAS-like alteration have a better prognosis compared to those with isolated BRAF, V600E mutations, and these other alterations listed here. And the co-occurrence of one of these alterations with additional mutations in the p53 gene or the TERT promoter gene are often associated with the worst outcomes. So as a case in point, I thought this following case study would be a really illustrative example of how molecular testing can be used for tumor prognostication. So this patient is a man in his 70s. He was found to have an incidental left thyroid nodule that was detected on a PET imaging for a lung nodule. And a thyroid ultrasound revealed a 1.3 centimeter, really small, a hypoechoic solid nodule, which underwent FNA. The FNA was very cellular, consisted of an exclusive population of variably sized, singly dispersed oncocytic cells. So the case was classified as oncocytic neoplasm, Bethesda category 4. Molecular testing was performed, this time with ThyroSeq, and it revealed a p53 mutation in addition to chromosomal copy number alterations. And these changes were interpreted by the ThyroSeq's molecular pathologists as having about an 80% probability of cancer, with the findings most likely representing oncocytic carcinoma based on these copy number alterations. And the report went on to say that if this is cancer, the presence of the p53 mutation is associated with more aggressive tumor behavior. So for this cytologically indeterminate nodule, follicular neoplasm or oncocytic neoplasm, these alterations suggested a high probability of cancer, and it forecasted a high-risk aggressive cancer at that based on the presence of the p53 mutation. So based on this molecular report, the patient underwent a total thyroidectomy, even though this was a very small tumor, a little over a centimeter. And that total thyroidectomy revealed a small but widely invasive heterogeneous nodule in the left lobe. And it's clearly malignant, isn't it, based on its widely invasive low-power appearance. And while much of the tumor did, in fact, consist of oncocytic cells with abundant granular eosinophilic cytoplasm, these oncocytes were mixed with a poorly differentiated component, seen on the upper right, with solid and trabecular architecture, pale instead of oncocytic cytoplasm, perineural invasion, and numerous mitotic figures, including 4 mitoses in this field alone, altogether diagnostic of poorly differentiated thyroid carcinoma arising from an oncocytic carcinoma. This was an eye-opening case for me because it highlighted the power of genotyping-based tests for tumor prognostication. In this case, the detection of a p53 mutation and its known association with aggressive cancers probably played a role in the decision to proceed with a total thyroidectomy as the initial surgical approach. And that was necessary in this case because the patient will likely require radioactive iodine treatment. And if we didn't know about the p53 mutation and how it was associated with aggressive clinical behavior, the small size of the tumor might have prompted lobectomy initially, and then that patient would have had to come back to undergo a completion thyroidectomy at a later date in order to initiate radioactive iodine treatment. And as predicted by the molecular testing results, there was a structural disease recurrence for this patient. He received radioactive iodine after the total thyroidectomy, was noted to have lung nodules that were increasing in size by serial imaging, together with an increase in the serum thyroglobulin level. And biopsy of one of these lung nodules confirmed metastatic, poorly differentiated thyroid cancer. Now, cases like this bring up an interesting question about whether molecular testing should be done for all malignant thyroid FNAs. And at this point, routine molecular testing for thyroid FNAs that are suspicious or positive for malignancy is not yet firmly established. But do keep in mind that this type of molecular risk stratification or molecular prognostication of a tumor, together with its clinical and radiologic features, can really help clinicians select treatment options that are proportionate to the tumor's prognosis. And to close, let's take a look at some additional uses for molecular testing that are emerging for thyroid FNAs. For patients with advanced thyroid cancers that are no longer amenable to the standard surgical and radioactive iodine treatment, for these patients, testing for actionable driver alterations like the ones listed here may help guide the selection of systemic therapy or direct patients towards clinical trials that are tailored to a tumor's particular molecular profile. And in this context, the ability to perform and detect molecular alterations on FNA cytology samples prevents the need for more invasive surgical procedures solely to collect sample for predictive biomarker testing. And finally, although thyroid FNA-based molecular testing is primarily intended for the detection of somatic alterations in tumor cells, these tests may incidentally identify germline mutations suggestive of hereditary cancer syndromes as well, including those that are listed here. And although this is really not the main purpose of thyroid FNA molecular testing, just being aware of the genotypes and the clinical phenotypes of these syndromes can help prompt genetic counseling, further evaluation for germline testing, screening of these patients for any associated tumors, and even consideration of testing of relatives as the current guidelines for these hereditary cancer syndromes may indicate. So altogether, in addition to its established role as a diagnostic tool for risk stratifying cytologically indeterminate thyroid nodules, molecular tests have a number of emerging applications for thyroid FNAs as well, including those that can help in the management of nodules that are suspicious or malignant. So in summary, in terms of molecular testing, keep in mind that in addition to this very well-established role of molecular tests for risk stratifying these indeterminate thyroid nodules, the well-characterized associations between a tumor's molecular profile and their prognosis can be used to guide decisions regarding the extent of surgery, lobectomy versus total thyroidectomy. And finally, in patients with advanced thyroid cancers that are not candidates for the standard surgical or radioactive iodine treatment, we're starting to see an emerging role for molecular testing in the selection of targeted therapies as well. It's clear that patients harboring the entire spectrum of thyroid tumors, from benign all the way to the most aggressive types, can stand to benefit to some degree from the integration of molecular diagnostics with clinical radiologic features as well as cytologic evaluation. So that brings us to the end of our thyroid session. The main points to take home with you are that for most thyroid FNAs, we can make a diagnosis based on the assessment and integration of just two key features: nuclear features and architectural features. And for those cases that fall into that gray zone, indeterminate categories, ancillary molecular testing for molecular changes has emerged as a pretty useful way to guide the next steps in management. And with respect to molecular testing, by making sure that all of us have a broad understanding of why we test, what we're testing for, and how these tests are performed, all of us here can help promote the judicious selection, the use, and interpretation of these tools in our respective practice settings. Thank you all very much for your attention, and I'm happy to stick around to take any questions.